What gives our skin its unique colors and patterns? Today, we'll explore benign pigmented lesions and uncover the hidden stories behind their colors and clinical features. After our opening, we'll journey through pigment cell types, dermal melanocytosis, melanocytic nevi, special pigmented syndromes, and uncommon Nevic variants. Each topic reveals a new layer of understanding. To begin, we need to understand the different pigment cell types found in the skin. What distinguishes melanocytes, Nevus cells, and melanophages? And how do they shape the appearance of benign pigmented lesions? Here's how melanocytes function and contribute to skin pigmentation. Solitary dendritic cells are small and regular, with dendritic cytoplasm typically found in the epidermis. Pigment production by melanocytes leads to features like freckles, lentiginous, and melanotic macules. Nevus cells differ from melanocytes, forming clusters and benign tumors. Clustered arrangement of Nevus cells with round or spindle cytoplasm is seen in the dermis. Nevus cells can form benign tumors such as junctional, compound, and intradermal nevi, including special variants. Melanophages play a key role in storing melanin and affecting lesion color. Melanophages are macrophages that store phagocytosed melanin granules. Melanophages contribute to the coloration of lesions, such as blue or brown hues. Notice how these cell types align in surprising ways when we compare their cytological features. Cytoplasm varies. Melanocytes are dendritic and solitary. Nevus cells are round or spindle in clusters, and melanoma cells can be round or spindle in clusters or large sheets. Nuclei are small and regular in melanocytes and Nevus cells, but large, irregular, and hyperchromatic in melanoma cells. Mitoses are rare in melanocytes and Nevus cells, but present in melanoma cells, highlighting their malignant nature. Next, we explore dermal melanocytosis, lesions where pigment cells reside deep in the skin. What makes Mongolian spots, nevi of Ota, Ito, Hori, and blue nevi unique? Here's how Mongolian spots present and what their histology reveals. Mongolian spots appear in infants, typically around ages 3 to 4, and fade spontaneously. These spots are usually found in the Pseudococcygeal region and resemble a bruise. Histologically, Mongolian spots show elongated dendritic cells in the lower dermis, with no melanophages present. Nevi of Ota and Ito differ in site and histology, but share pigmentation features. Nevi of Ota appear around the periorbital, temporal, malar, and nose regions, while Nevi of Ito are found in the supraclavicular, scapular, and deltoid areas. Both types show brown slate blue mottled pigmentation without induration. Histologically, these nevi have elongated dendritic melanocytes in the upper dermis, with a higher concentration than Mongolian spots. Nevus of Hori is distinct in its clinical and histological presentation. Nevus of Hori presents as acquired symmetric dermal melanocytosis, especially in Asian women. It is typically found in the bilateral malar region. Histologically, dendritic pigmented melanocytes are seen in the mid and upper dermis. Blue nevi come in several types, each with unique clinical and histological features. Common blue nevus is small, well-circumscribed, dome-shaped, and slate blue in color. Cellular blue nevus presents as a blue nodule, 1 to 3 centimeters, often in the buttock or sacrococcygeal region, and is heavily pigmented. Combined nevus involves a blue nevus associated with an overlying compound or intradermal nevus. The Tyndall effect explains why dermal melanocytosis appears blue. The blue color in dermal melanocytic lesions is due to the Tyndall effect, where light is scattered by melanin, especially short wavelengths like blue and indigo. This effect gives dermal melanocytic lesions their characteristic blue appearance. Notice how cellular blue nevus features align across gross and histological attributes. Cellular blue nevus is a blue nodule, 1 to 3 centimeters, often on the buttock or sacrococcygeal region, with heavily pigmented cellular tumors spanning the reticular dermis and involving superficial panicculus. Desmoplastic blue nevus features highly prominent collagen, sometimes leading to confusion with dermatofibroma. Now, let's examine melanocytic nevi, the most common benign pigmented lesions. How do their clinical presentations and histological types reveal the nature of these nevi? Melanocytic nevi present in various forms, from flat macules to dome-shaped and pedunculated lesions. Flat lesions appear as localized pigmented macules. Elevated lesions have a raised center with a flat periphery. Some nevi are dome-shaped or papillomatous. Pedunculated lesions have a stalk-like attachment. Nevus cell maturation is a crucial marker for benignity, with cell size and atypia decreasing as depth increases. Type A cells are found in the upper dermis, round cuboidal, and contain abundant melanin. Type B cells are located in the mid-dermis, smaller, with less cytoplasm and melanin. Type C cells reside in the lower dermis, are spindle-shaped, and rarely contain melanin. Dermal maturation is marked by decreasing cell size and atypia with depth, a key indicator of benignity. Notice how histological types of nevi differ in location, architecture, and cytology. Junctional nevus is located in the epidermis, or bulging into the dermis, with nests at the tips and sides of rete ridges and regular rounded or cuboidal cytology. Compound nevus features nests in both epidermis and dermis, showing maturation from superficial to deep, with decreasing cell size and melanization. Intradermal nevus is found exclusively in the dermis, forming cords and nests, with multinucleated cells in ring or rosette patterns, and neuroid nevus in the deep dermis. Let's compare Spitz nevus and Dysplastic nevus to understand their distinguishing features and how they differ from melanoma. Size distinguishes these lesions. Spitz nevus is less than 6 millimeters. Dysplastic nevus is greater than 5 to 6 millimeters, and melanoma is larger than 6 millimeters, or more than 1 centimeter. Symmetry is a key feature. Spitz nevus is symmetric, Dysplastic nevus is symmetric or uniformly elongated, while melanoma is asymmetric. Epidermal changes differ. Spitz nevus shows hyperplasia, hyperkeratosis, and hypergranulosis. Dysplastic nevus has a normal stratum corneum. Melanoma exhibits irregular thickness and common ulceration. Pagetoid spread is minimal in Spitz and Dysplastic nevi, but obvious in melanoma. Lateral growth is absent in Spitz nevus, horizontal or lateral in Dysplastic nevus, and radial or lateral in melanoma. Infiltrate and nesting patterns vary. Spitz nevus has single attenuated cells at the base, Dysplastic nevus shows patchy lymphoid infiltrate, and melanoma has band-like infiltrate, nests, and paucity in the reticular dermis. Pigmentation is little or absent in Spitz nevus, variable or patchy in Dysplastic nevus, and heavily pigmented in melanoma. Some pigmented lesions are linked to syndromes with broader clinical implications. What are these syndromes, and how do their skin findings connect to systemic features? Albright syndrome's melanotic macules are distinctive in their association and appearance. Melanotic macules of Albright syndrome are associated with unilateral polyostotic fibrous dysplasia and precocious puberty in females. Grossly, these macules are large, few, located in the midline on the same side as bone lesions, and have jagged borders. Histologically, there is hyperpigmentation of the basal layer, but the number and size of melanocytes remain normal. Becker's melanosis is notable for its clinical and histological features, as well as associated syndrome findings. Becker's melanosis presents in the second decade as a large unilateral patch with hyperpigmentation and hypertrichosis, often on the shoulder, back, or chest in males. Histologically, Becker's melanosis shows acanthosis, regular elongation of rete ridges, hyperpigmentation of the basal layer, and melanophages in the upper dermis. Syndrome features include increased hairiness, smooth muscle hamartoma, skeletal abnormalities, ipsilateral hypoplasia of breast or limb, and spina bifida occulta. Multiple lentiginous syndromes link skin findings to systemic and genetic features. Leopard syndrome includes lentigenes, ECG defects, ocular hypertelorism, pulmonary stenosis, genital abnormalities, retarded growth, and deafness. Elam syndrome features lentiginous nevi, atrial or mucocutaneous myxoma, myxoid neurofibroma, and blue nevi. Carney's complex presents with spotty skin pigmentation, myxomas in heart, skin, and breast, endocrine overactivity, schwannomas, and epithelioid blue nevus. Peutz-Jeghers syndrome is characterized by mucocutaneous pigmentation, gastrointestinal polyps, mutation of LKB1 STK11, and increased risk of thyroid, breast, lung, and pancreatic cancers. Notice how lentiginous types differ in site, clinical features, and histology. Solar lentigo appears on the face, forearm, and dorsum of hands, with uniform dark brown color and a regular outline, serving as a risk marker for melanoma. Histology shows elongated club or tortuous reed ridges and deeply pigmented basaloid cells. Lentigo simplex occurs in childhood as small, symmetric, well-circumscribed brown-black macules with increased nevoid melanocytes near the tips and sides of elongated rate ridges. Finally, we turn to uncommon Nevic variants. What makes these rare types stand out, and how do their histological features help us identify them? Balloon cell nevus is identified mainly by its histological features. Balloon cell nevus is rare and lacks distinct clinical features. Histologically, balloon cell nevus shows large balloon cells with small, round nuclei and vacuolated cytoplasm and is positive for melana/MART1. Acral lentiginous nevus is distinguished by its location and histological pattern. Acral lentiginous nevus presents as small, well-circumscribed, symmetric macules on the palms or soles, with dark ridging along dermatoglyphics. Histologically, nests of nevoid, or small epithelioid melanocytes, predominate near the dermal-epidermal junction, arranged in a contiguous, evenly spaced pattern. Spitz nevus stands out for its clinical and histological features. Spitz nevus occurs in children and young adults, presenting as a solitary, hairless, small, pink, dome-shaped nodule, 6 mm or less. Histologically, Spitz nevus can be compound, junctional, or intradermal, with large plump spindle and epithelioid giant cells and artifactual clefting between nests and stroma. Neuroid nevus is defined by its histological and immunohistochemical features. Neuroid nevus features type C spindle cells in the deep dermis, embedded in collagenous fibers, forming structures resembling Meissner's tactile corpuscles. Immunohistochemically, neuroid nevus expresses S100, myelin basic protein, and GFAP. Benign pigmented lesions reveal a world beyond skin color. Clinical features, histology, and syndromes all shape how we diagnose and understand benign pigmented lesions. The story of skin color is truly more than meets the eye.